Okay, let's dive in. We all know that feeling, right? You've got this pile of dense notes, maybe for revision, maybe just trying to really get your head around a difficult subject.
Yeah, and making sense of it all, turning those facts into something you can actually remember and, more importantly, use. That's tough.
Especially with the topic as critical and, let's be honest, as sensitive as suicide.
Exactly. So you shared your revision notes on this, and that's what we're going to tackle today. Our mission, really, is to help you unpack this material.
Find those key nuggets of information.
Yeah, the really high-yield stuff, and structure it conversationally so it sticks, not just reading off a page.
We'll work through everything that's in your notes: definition, causes, the risk factors, the sort of medical understanding, the numbers.
Clinical features, assessment, management.
Right, all the way through to prognosis and the wider impact. We'll approach it carefully given the subject, but focus squarely on the facts presented in your material.
Okay, so where do the notes suggest we start? Definition seems logical.
Yes, they kick off with that core definition: intentional self-inflicted harm that leads to death. Pretty clear.
It is, but the notes immediately add that crucial layer of complexity. They frame it not just as an act, but as a deeply complex issue. Emotional, social.
And a major public health concern.
Absolutely. It's not just one thing.
And the notes are clear when we say suicide, it's actually a spectrum, isn't it? It covers the thoughts, ideation, then attempts, and then completed suicide.
Right. It's a process, potentially. It always involves that self-inflicted harm with the intent to end life. And crucially, the notes point out it can be multifaceted. It might even result from patterns or difficulties over many years.
That longer perspective is important. Okay, so that's the what. What about the why and the who? Etiology and risk factors, the section in the notes looks quite detailed.
It really does, and it frames the causes, well, highlighting that it's usually this complex mix, isn't it? Individual things, relationships, even wider societal factors.
It's rarely just one single cause. And the notes list specific risk factors. Mental health conditions and substance abuse are right up the top.
Yeah, absolutely critical points there. And history plays a big part, too. A family history of suicide is mentioned as increasing risk.
And previous attempts seem really significant.
Hugely significant. The notes rightly highlight that previous suicide attempts are one of the strongest predictors of future attempts. That recurrence idea is key for revision.
Access to lethal means is also listed. A stark point, but it shows how opportunity can intersect with intent.
Yeah, definitely. And then there are the social and health dimensions.
Hmm.
Social isolation, chronic illness, both listed as risk factors. You can imagine the burden of feeling alone or constantly battling a health problem.
Recent life stressors, too. The notes mention things like money troubles, relationship breakdowns, things that can feel overwhelming.
Exposure is another one, being exposed to suicidal behaviors in your community or social circle. It suggests perhaps a kind of clustering effect sometimes.
And specific demographics are highlighted.
Yes. The notes mention middle-aged men and individuals from marginalized communities as potentially being at higher risk, according to the data they present.
It's quite a heavy list of risks, but I noticed the notes immediately follow up with protective factors, things that can actually help.
Which is just as important to remember, especially for revision. Things like strong family support, having children, religious belief, they're explicitly mentioned as protective.
It highlights connection, responsibility.
Belief systems, yeah. Things that anchor people.
So moving from risks to the underlying mechanisms, the pathophysiology section, the notes seem to describe this using that biopsychosocial model.
That's right. It brings together biological, psychological, and social elements. Biologically, the notes mention neurotransmitter imbalances. Serotonin is given as an example.
Okay. And psychologically.
They point to those really powerful internal states. Hopelessness, deep despair, feeling trapped with, no way out.
And socially.
Things like the stigma around mental health, which can stop people seeking help, limited access to care, isolation, all contributing factors.
Right. Now, shifting slightly, but really important when a death has occurred. Differential diagnosis. The notes stress ruling out other possibilities.
Yes, absolutely essential. Was it accidental? Was it natural causes? Or, tragically, was it harm caused by someone else? You have to establish the manner of death accurately.
And the process described sounds thorough: medical exams, toxicology, a psychological assessment.
Understanding the context, the person's state of mind leading up to it, mental health professionals play a key role in that, according to the notes, for an accurate determination.
Okay, let's look at the numbers. Epidemiology. The notes call suicide a significant UK public health issue, and mention increasing rates in some age groups.
Yeah, and a really key point from the data presented is that gender difference. Men tend to have higher completed suicide rates, while women have more attempts. That's a classic distinction to be aware of.
And it varies across the country.
It does. The note suggests regional variations linked to social, economic, and cultural factors.
Are there specific figures we should pull out?
Well, the notes mentioned 5,821 suicides recorded in the UK in 2017. They also note a general declining trend since 1981, which is positive, though it does fluctuate.
But within that, there are peaks.
Yes, for that 2017 data point, the highest rates were noted in men aged 45-49 and women aged 50-54. That age bracket is worth remembering.
Methods.
Hanging and poisoning are listed as common methods. And this is really critical. The notes state a significant number of those who died by suicide had prior contact with health professionals.
That flags up potential points for intervention, doesn't it?
It really does. It suggests the healthcare system is often involved at some point beforehand.
The notes also mention the global picture.
Briefly, yeah, citing the WHO estimate of over 800,000 suicides annually worldwide. Puts the UK figures in context.
So if that's the data landscape, how might suicide risk actually, present itself? Clinical features. The notes say signs vary hugely.
They do. There's no single checklist, but the notes give potential indicators. Things like expressions of hopelessness,
Talking or writing about death or suicide.
withdrawing socially,
Changes in mood, maybe behavior,
giving away belongings,
increased use of alcohol or drugs.
engaging in reckless or risky behaviors.
Okay, quite a list. But there's a massive caveat here, isn't there?
Absolutely massive and vital. The notes stress this. Not everyone shows clear warning signs. Some people conceal their intentions incredibly well. You just can't rely on seeing these signs.
Which leads straight into the section on mental disorders and suicide risk.
Yeah, and the link is stark. The notes state individuals with mental disorders have a significantly higher risk, maybe 5 to 15 times higher compared to the general population.
Wow. And the stat about underlying mental illness.
Around 90% of individuals who die by suicide are estimated to have an underlying mental illness, according to the source material.
And specific to the UK notes.
About a quarter, 25%, of those who die by suicide had been in contact with mental health services prior to their death. Again, highlighting that contact point.
The notes also list common diagnoses found in UK victims.
Yes, affective disorders, especially depression, schizophrenia, personality disorders, and histories of alcohol or drug misuse. You can maybe group them for memory. Affective, psychotic, personality, substances.
Good way to frame it. Okay, so given all this complexity, how do we investigate after death and, crucially, assess risk in someone living?
The notes cover both. For investigations after death, they talk about a comprehensive approach,
Which means?
looking at everything. Circumstances, interviews with family, medical records, toxicology, that psychological assessment we talked about.
Needs collaboration.
Definitely. Law enforcement, medical teams, mental health experts working together.
And for assessing risk in a living person, this is all about prevention.
Exactly. Not about predicting perfectly you can't, but about understanding the level of risk to guide what you do next.
The notes give clear steps. Start with open questions, build rapport.
Trust is foundational. Then you explore those risk factors we discussed. Mental health history, depressive symptoms, medication, substance use, their current mental state as you see it.
Previous self-harm or attempts.
Crucial, remember that recurrence risk. Also age, gender, social situation, relationships, and importantly, do they have access to lethal methods?
But the real core seems to be assessing current intent.
Absolutely. This is where you explore. Have they made plans? How specific are they? When? Where? How do they feel right now? Hopeless? Trapped? Any regret? What do they think will happen?
That ES pathworm mnemonic you mentioned earlier could be useful here, even if not explicitly in these notes, just to cover those bases: ideation, substance use, purposelessness.
Anxiety, trapped, hopelessness, withdrawal, anger, recklessness, mood changes. Yeah, it covers the key domains the notes are pointing towards.
And the notes list specific red flags, things that really increase concern.
Yes. Strong feelings of hopelessness or being trapped, having well-formed plans, lacking social support, experiencing psychotic phenomena like hearing voices telling them to harm themselves, and significant physical pain or chronic illness.
Now, there's a really important point about scoring systems.
Yes, critical for practice and revision. The notes highlight that NICE guidelines specifically state that risk-predicting score systems are not recommended for assessing suicidal intent.
So no relying on just a number.
Exactly. The emphasis is on a thorough clinical interview. It's about the conversation, exploring all those factors, not ticking boxes on a scale. That's the gold standard, according to this material.
Okay, that makes sense. So understanding the risks, assessing it. What about management? How do we help?
The notes outline a multifaceted approach. It starts broad. Crisis helplines, support groups, counseling, all valuable.
And specific treatments.
Psychotherapy is mentioned prominently, particularly CBT and DBT. Medication too, antidepressants, mood stabilizers. The notes even briefly mention ketamine research as something being explored, and sometimes hospitalization is necessary.
The notes lay out general management steps.
Yeah, a kind of framework. First, pull together your summary and risk assessment. Then, tailor the plan it has to fit the individual's specific level of risk.
Maintain that supportive relationship.
Crucial. And practical steps like helping remove access to means where it's safe and possible.
Consider their willingness to engage. Think about referrals. Maybe even a mental health act assessment if needed.
Right. If the criteria are at a significant risk due to a mental state, then work with them, if possible, on a collaborative care plan.
What goes in that?
Short and long-term goals, strategies to manage risk, and a clear crisis plan. Who do they call? What steps do they take if things get tough again?
And follow-up is key.
Essential. The notes particularly stress this after starting antidepressants, as that initial period can be a bit tricky sometimes.
What about someone deemed high risk right now?
The notes suggest ensuring 24-hour support is available, maybe through a local crisis team. Psychiatric evaluation should be considered.
And potentially mental health act detention.
If necessary, yes, if the criteria are met. But, important point from the notes, this isn't just for being drunk or high on drugs. There needs to be an underlying mental disorder contributing to the risk.
Okay. And safety planning is part of this whole process.
Definitely. Writing down those coping strategies and contacts, it's a tangible tool for the individual.
Looking further ahead, what about prognosis?
The notes say it really varies. It depends heavily on getting support, getting it quickly, and how well the treatment works for that person.
But early intervention helps.
Yes, the notes are clear. Early identification, prompt help, and ongoing support genuinely improve outcomes. It makes a difference.
But it's individual.
Always. Depends on their circumstances and response.
Lastly, complications. This isn't just about one person, is it?
No, the notes emphasize the ripple effect. There's a huge emotional and social impact on the individual if they survive an attempt, but also profoundly on family, friends, the whole community.
Especially for those bereaved by suicide.
Immense emotional trauma for those left behind, often called survivors of suicide loss. And the notes mention stigma complicates that grief terribly.
And that can lead to more mental health challenges in the community.
It can, which underlines why we need not just prevention, but also postvention dedicated support for those bereaved.
Okay. Well, we've really worked through the layers presented in your notes definition: causes, risks, the medical side, stats, signs, assessment, management, impact.
It's a lot to take in.
It is. We hope that talking it through like this, breaking it down, has helped make those dense notes a bit more, well, manageable and memorable for your revision.
Absolutely. And maybe a final thought to leave you with, based on everything we've discussed from these notes. Considering all those complex factors, individual, interpersonal, societal, and also the protective ones like connection and support, how can you, perhaps in your future clinical role, or even just as a person in your community, best contribute? How can we help spot risk and actively build those protective connections?
Something to really reflect on. Thanks for joining us for this deep dive into such an important, though difficult, topic. We hope it's been a useful session for your learning.
And if you find this way of breaking down information helpful, especially if you are revising for something like the MSRA, you might want to check out passthemsra.com for more structured revision content.
Yeah, and for free resources, question banks, and the like, definitely take a look at freemisra.com as well. Good luck with all your revision efforts.